Hello and welcome everybody to our brunch of the week. Month actually. We haven't done one for a little while, have we? We are here today with the fabulous heart failure nurses and Vicky Ruszala. How do you say your surname, Vicky? Ruszala.
Ruszala, yeah.
Ruszala, who is a fabulous pharmacist in diabetes and cardiology. Is that right, Vicky?
Yeah, I've gone to the dark side. I'm actually just cardiology now.
Oh,
I just can't forget the diabetes.
But you won't ever forget it though, will you? So just while everybody's joining, I think we have an icebreaker question that we might want to go through just while we're and then we'll introduce ourselves. So I'm gonna ask Beth first. If you had your human head but the body of an animal, which one would you pick?
So yeah, I'm Beth. I'm a diabetes nurse from Wiltshire.
On the icebreakers once everybody started joining.
Okay, cool. I think I would pick something really flamboyant, like a flamingo, just because why not? I don't know, but that's really hard. Yeah, I think I'd go with flamingo.
Yeah. Poppy, what about you?
So it's body, not head, right?
Yeah, I mean, I think we can be a bit lenient, you know, with the rules.
That's easy. I think I would go for cheetah so I could run really fast.
Oh,
that's exactly what I was going to say, Poppy.
It's because we need to run away from all those cardiologists.
And what about you?
Hi, I'm Tamsin. I'm a diabetes specialist nurse at the Royal State University Hospital, and I was going to say just like a cat, basically, because I have 5 cats and they are all very crazy. So yeah, I was going to say just like a general cat, basically.
So what about Vicky A? We're going to have to go Vicky A and Vicky R today.
Well, Tamsin's stolen mine. I was going to say cat, so I'm going to give a slight different variation and say meerkats because they are small and they can hide, and I think they're quite cute.
And they can compare your car insurance.
That as well.
Vicky R?
I'd go like eagle or hawk or something, like a proper like bird of prey, so you could fly really high and really fast. So I like the idea of flying.
Yeah, I think I'd go for a bird of some sort. Okay, so I think people have joined now. We've got quite a few people watching. So please do put your questions on Facebook in the comments and we will read them out live and we will ask all of our lovely people that we have here today. So let's do some introductions. My name is Amanda and I am a diabetes specialist nurse in East Kent now. Just started a new job, so I have to remember that I'm not in Medway anymore. I'm in East Kent now. Beth, where do you work? What do you do?
I work in Wiltshire, a little bit north of me.
Okay, Vicky A.
Yes, I'm Vicky. I work within the Eden education team at Leicester Diabetes Centre, and I've been there for nearly a year.
Tamsin?
I'm Tamsin and I'm a diabetes specialist nurse and lead for the Royal State University Hospital.
Vicky R? No, okay. Poppy?
Sorry, I'm shouting at my children who have promised me
I did think that.
I am a heart failure. I am what am I doing? I'm a pharmacist. I worked in diabetes for 12 years and I now have moved to cardiology and do heart failure.
And who are your children in the background? Shall we say hi?
Oh my God. Max and Toby.
It's just the fun of working from home, isn't it?
Like I've given them snacks, I've given them TV, everything.
Oh,
they're my twins.
Okay, Poppy.
I am Poppy Brooks. I'm a heart failure nurse in North Devon. I cover inpatient and community care, and I'm the chair of the BSH Nurse Forum.
Wow. And then we have Becky.
Hi, I'm Becky. I'm a heart failure specialist nurse at Salisbury Hospital, and I'm also on the BSH Nurse Forum with Poppy.
Brilliant. So lots and lots of experience here today. Beth, did you want to start with the questions?
Oh, well, I think I was going to ask basically, so obviously we've got both the diabetes and the heart failure teams, and it was just to maybe briefly, I think all diabetes nurses, we don't really understand and heart failure, and probably vice versa a little bit. So I was just going to ask, because we've got so many healthcare professionals that do watch this, if you guys could just explain to us, maybe in very easy to understand terms, what the difference is between HFpEF and HFrEF. I don't know which one of you guys want to take it. Silent.
Yeah, I don't mind taking it. So firstly, you know, heart failure in itself is actually a syndrome. So it's categorized as a clinical syndrome of the symptoms of breathlessness, fluid retention, and fatigue. So patients can have structural issues with their heart without having any of those symptoms yet. But once they do develop those symptoms, it's very important that we get actually a diagnosis of what issue is causing those symptoms, and to confirm that it is heart failure, because obviously those symptoms can be caused by other things. So the first step in doing that for people who suspect heart failure in their patients would be getting an NT-proBNP or BNP blood test, and there'd be different cut-offs locally for what counts as positive, and that should be, you should have local guidelines on that, and who can order them. And then each local service should have referral criteria to refer in with a raised NT-proBNP. Should be done urgently in some cases within 2 weeks, to see a specialist and get an echocardiogram at the same time. On the echocardiogram, there will be an assessment of the structure of the heart, looking at the atria, the ventricles, the valves. Some people with heart failure might have valve disease, and that could cause heart failure symptoms. Some people might have heart failure with preserved ejection fraction, and some people might have heart failure with reduced ejection fraction, and those are the two terms that I think people are getting confused about. So ejection fraction refers to when the left ventricle squeezes and ejects the blood out of the chamber into the rest of the body. A lot of patients get confused because they think a normal ejection fraction should be 100%, but actually that would be hyperdynamic, that would be abnormal as well. Actually, the cutoff, as per the new ESC guidance, would be about 50%. So a patient who's got heart failure symptoms and an ejection fraction of less than 50% could be categorized as heart failure with reduced ejection fraction overall. But most of the evidence on the drugs that we use in heart failure with reduced ejection fraction actually is based on trials where they've only included patients with ejection fraction of less than 40%. So the strong evidence we've got for a lot of the drugs we use are the patients with 40% and below, and in some of the treatments 35% and below. So there is also this other term that you might hear of heart failure with mildly reduced ejection fraction, or mid-range is what it was called before the latest guidance. So we've made it more difficult for everybody to understand because we've got all of these different terms going around. Yeah. And we used to call HFpEF, HFnEF, didn't we? Heart failure with normal ejection fraction. So, and what we can't assume is that if somebody's got symptoms of heart failure and they've got a normal ejection fraction, that they've got HFpEF either. Somebody with HFpEF will usually have some form of structural abnormality on their echocardiogram. So it might be that their atria are dilated and therefore less effective, even though the left ventricle's pumping well. They might have some diastolic dysfunction. So that means although the left ventricle is squeezing well, it's not then relaxing properly. Or they might have whilst their left ventricle is pumping with great strength, it might be enlarged. They might have some left ventricular hypertrophy. So there would normally be some abnormality on that echo. So that's why it's really quite nuanced. And if we suspect heart failure, we should be referring to the cardiologists or the specialist teams, because it's not just cardiologists that do the suspected heart failure clinics, and get a proper diagnosis of what kind it is. And it's really important we know, because as you know, some of the treatments are relevant for HFrEF and some of them and not much is relevant for HFpEF. So we have to be careful with what drugs we're using for which patient. But if they're congested, then all of them will need some diuretics, and that's the bulk of what we do. I hope that makes sense.
Yeah, that was like super quick in 5 minutes. Yeah.
Sorry, I do talk fast. Tell me to slow down.
No, that's fine. I just meant it's like trying to squeeze your whole speciality into 5 minutes. Yeah. We get asked that a lot about, like, talk about the types of diabetes, and you're like, oh my God, where do I start?
Yeah. So as you know, we're live on Facebook at the moment, live streaming, and we have some questions. So Vicky, I think there's a question there. Did you want to ask that one?
Yeah, thank you, Amanda. Yeah, so the first question from Facebook, I don't know who wants to take this one, but are you using SGLT2 inhibitors? Obviously, we all want to know about that.
Or what?
or heart failure.
Yeah, we could ask all of them, as both of the HFpEF and HFrEF, I guess, because
yeah, it doesn't specify
trials
in the
and
question.
evidence
It just says,
now, isn't there?
are you using them?
So yeah, I think we are using them for HFrEF patients for sure. It is interesting for us as heart failure nurses, because if they don't have diabetes, we feel much more comfortable about using it without having to think about the other side of their comorbidity so much. But yeah, we're using it more and more, and actually I think it's the one that we're prescribing the most of at the moment. I would say we're really getting as many people we come into contact with, getting them started on it as soon as possible.
And I don't know about you guys, but my patients, regardless of why they're on it, feel better. It's the one that they start and they feel better because they're on it. And
it seems to be well tolerated by so many people. I mean, I think because a lot of the other ones are affecting their blood pressure or the heart rates, and it seems like this one is quite well tolerated by patients.
Yeah. I think the blood pressure thing is a big thing. There are a lot of patients who I've struggled to titrate their other drugs that benefit their heart failure, and because their blood pressure is on that lower end, and I'm less nervous with getting them on an SGLT2, and so it's a nice choice. The other thing that makes it, we were talking about, Becky, weren't we, that makes it a nice choice for us as heart failure specialists is, we're trying to, with HFrEF, we're trying to get patients on 4 drugs, and the other 3 we're nudging them up gradually, and we're chopping and changing, and they don't tolerate it, and we change up, down, left, right. With dapagliflozin or empagliflozin, we can just go straight in at 10 milligrams, and you've got a quarter of their treatment is just done with that one prescription. So I think you're probably seeing a lot of heart failure teams quite keen to prescribe it at the moment.
Do you see any effect on the blood pressure? Because obviously, I think some of the secondary endpoints in some of the early trials did show a slight reduction in, or the real world evidence did show a slight improvement in blood pressure, but is it sort of not significant compared to the other drugs that you use?
Not really.
I've not noticed a noticeable change.
In the diabetes trial, it was non-clinically significant. So it was tiny little drops of about 5 to 10 millimeters of mercury. It wasn't clinically significant. When we were looking at it in diabetes, our patients had these massive hypertension. It just didn't matter. In heart failure, we're not really, and a lot of the problem with it is because of the fluid balance changes and stuff like that. Like, we don't really notice.
Yeah, thanks. I was just interested.
So, and there's a question on here, what drug would you use? I mean, I think you kind of covered it a little bit, Poppy, but Vicky, did you want to go into why you would use which SGLT2 for which patient? Or
I mean, a lot of it's licensing related. The only ones with licenses are DAPA and EMPA. DAPA is benefiting from having a nice technology appraisal, so it's really making life easy, and we're just doing DAPA. Having said that, EMPA is now putting through with licenses for other things like preserved, but they don't have the technology appraisals from NICE, and so I think that's staying the hand a little bit, because CCGs are seeing an explosion. So our formulary committees and stuff are seeing an explosion of these drugs being prescribed, and it's causing problems financially. The interesting thing in cardiology is that using these drugs stop people coming into hospital. So it's really easy for us to get these onto the formulary, because it costs a lot less to prescribe these drugs than it does to not prescribe them. That's not the same as what we've had in diabetes for years and years, where we've been battling to get these medicines used first line. But the benefit of using them in diabetes is 10 years later. We see them in 3 months' time. So we get in-year savings by using them. So it's a walk in the park to get these through formulary. So at the moment, DAPA and EMPA are leading the way. Canna is not publishing anything on heart. So we've kind of left that to one side from a heart perspective.
Brilliant. So talking of guidelines, Vicky, did you have, not Vicky, Tamsin, sorry, did you have a question about the NICE ESC?
Yeah, so it was just really which guidance do you kind of go to first with regards to these, to treatment really? Do you use NICE, NG28, the new guidance, if they've got diabetes, and do you use your own guidance if they're just heart failure with no diabetes? Where do you kind of go with regards to starting medications?
It's difficult, isn't it? Because there's a lot of different guidance there, especially for these patients now that are crossing over between different specialities and maybe they've got more than one indication for the drug. We tend to, in heart failure in general, the ESC guidance is a lot more detailed than the NICE guidance. If you want, it's 127 pages. If you wanted to know anything about heart failure, if you read that guidance, everything's in there. There's nothing left out. It's the whole lot in all of its nuance. But the NICE guidance is obviously more, it's an easier, quick reference, and but it's less up to date as well. It's 2018, the ESC guidance is 2021. So SGLT2s aren't even in the NICE guidance, but we have got the NICE technology appraisals. And I think the empagliflozin for HFrEF came out last week, actually, did it? But we haven't got the HFpEF. We don't know what they're going to say about that yet. So it's trying to bring both of those things together, really. And I think as specialist nurses, I often find that, you know, we really do need to kind of lean quite heavily on the guidance, and in terms of NICE, that's what's been improved sort of funding wise. So we're going to struggle to get formulary teams to agree things that don't comply with what NICE recommend in terms of who we can prescribe the drugs for. So yeah, but you know, the ESC provides a bit more context and a bit more information and maybe a bit of rationale. If you are on the cusp of a guidance somewhere and you're trying to make a case, then that can help to back you up. I don't know what the others think, Becky and Vicky.
Yeah, I think the same. As a non-medical prescriber, we do really, you know, as you said before, Vicky, the consultants can go a bit rogue sometimes, but certainly from our point of view, we're following NICE. Although I would agree, I think the ESC guidelines are really comprehensive and really helpful for that sort of overarching care of heart failure patients. But yeah, we are kind of led by what NICE say. Yeah,
and I think we need to be make sure that we detach licensing from NICE, because I think people get really confused by that. The licenses exist when the evidence has been presented to the EMC, MHRA now in the UK, to show that there is effectiveness in the population that it's coming out at. So the licenses, for example, HFpEF, do exist for empagliflozin, but NICE and guidance have not caught up to that, and the cardiologists and the consultants tend to go with licensing because it allows them to do more, whereas as you highlighted, most other people are following guidance. And I think what the cardios often say is guidance is just that, it is guidance, it is not a set of rules. And I think especially now we've got these crossovers between diabetes and cardio and kidneys, the guidance is really struggling to put this into thing, and we're getting a lot of people being shackled by what guidance says when actually they're not rules, and that's where the cardios especially are like, I'm going to do what I like. So.
And that's where I think we need to have like wider conversations, isn't it? You know, that's where the MDT discussion comes in. And do you think that it's important that we document what indication we're giving the SGLT2 inhibitor, you know, and if it's more than one indication, that we state that? Because going forward, if the patient needs to stop it for any reason, then what's the alternative? You know, does somebody need to be finding an alternative for the diabetes or for the kidneys or for the heart failure, or all three? So do you think it's important that we document that when we start it?
Yeah, I think when it started, I think that documentation is so essential, and it's something that I put a lot of time into on discharge summaries and outpatient letters. So I will often make very bold statements. So patients who do not have diabetes, I will say, this is for heart failure, please do not stop it. And I will literally specifically say that. If they don't have diabetes, I will say that. If they do have diabetes, I will often then say, this is for heart failure, please only stop this if there is a reason, a reason for their diabetes, if they're at risk of DKA, you know, and please restart as soon as possible. So I'll put those kind of things in my letters and in the discharge summaries for the cardio ward that I cover, to make sure that people are clear, because I completely get why it's so confusing in primary care, and they've only ever seen this for diabetes, and every person I meet in primary care starts with diabetes and then moves to heart failure or kidneys, because that's what they've been trained in for the last 5 years. And we've had our diabetes team saying, you know, high risk of DKA if they become unwell, stop when, you know, during COVID, everybody was pre-heart failure use, everybody was being told to stop this on admission to hospital. because of the risks of DKA that we were seeing. So they're being told to stop it on admission to hospital, restart it when they go home. Well, that's fine when you have using it for diabetes and we can give insulin to cover and piclazide and other things when they've got high blood glucose. But if they've got heart failure, we don't want them in hospital for 3 months with COVID, not having their heart failure medicines. So we've really muddied the water by increasing these indications, and we need to be clear, and we're really terrible at sharing in secondary care, certainly with sharing with our primary care colleagues what we want them to do. We just don't tell them.
Yeah.
We just assume they're going to pick it up from all the reading that we've had plenty of time to do as specialists, and that they'll just kind of randomly know who's supposed to stop and start. And I think that's where the real work and effort needs to be put in, which is saying, when do you stop it and when do you start it?
That brings us to our next question, sick day rules. So in terms of diabetes, Beth, do you want to go through if person had diabetes, when you would stop and start? And then maybe we can sort of add in the bits for the heart failure as an add-on.
Yeah, so I guess if you're prescribing SGLT2s for people living with diabetes, you would stop it in any times of acute illness. So when they're possibly not eating and drinking, they've got then they're at risk of kind of volume depletion, because obviously adding in an SGLT2, that's what it's doing to them, is kind of getting them to pee out all that extra sugar down to the toilet. So if they're not eating and drinking for very long, we would normally recommend stopping it alongside other drugs that we might prescribe for diabetes as well, like metformin. We would also stop that in acute illness, which I think is something we do. That's usually the root of the problem, isn't it? That people haven't counselled the patient on that, and so they end up possibly going into hospital. So that would be what we normally recommend with SGLT2 therapy, is to stop it when acutely unwell. But it's interesting that I think that's where maybe it is, like Vicky said, that they don't necessarily stop it for heart failure or for the kidney side. So what do you do when they've got a bit of everything? Yeah. Got lots of questions.
There are some more questions, I think. Hang on a second. Vicky.
Yeah, David Miller, who we know is another pharmacist, has asked about, do you go with SGLT2 inhibitors or Entresto first once other heart failure meds are optimized in patients without diabetes? So I know Vicky is the superstar about Entresto. Tell us what it is.
I was going to say, can you explain what it is first, because it sounds like a Disney film.
I mean, I'm not sure you really want to ask me about it. I think the nurse is a better place to talk about Entresto. I think, to be fair, personally in my clinic,
do you want to take it?
I mean, I would just say, but personally in my clinics, I start Entresto, give them the prescription for DAPA at the same time, tell them to start them a week later, so we know if they get any side effects. But otherwise, I start them at the same time. So that's my thing. I can go back to that if you want, but I think explaining what Entresto is, I think, needs to be the nurses.
Okay, so Entresto is a relatively new kid on the block in terms of heart failure management, and it's two medicines in one tablet. The valsartan is a known ARB. We used a lot in cardiology, and the new part is sacubitril, which is a neprilysin inhibitor, and it's to do with the breakdown of the BNPs that we measure in heart failure. It was just overwhelming in some trials that management of HFrEF, that Entresto or sacubitril valsartan was beneficial above the ACE or ARB we traditionally used. So we use it quite regularly in the HFrEF population. It is quite a strong vasodilator, so it does push the blood pressure quite hard, I think. Poppy, would you agree? So we do need to monitor, although as we said before, we're braver with blood pressure than many of our colleagues in other specialties. And as Victoria just said, actually, I probably do give them a prescription for both. But as with any prescribing, I tend to say don't take both at the same time, because if you have a side effect, who knows what caused it? So, but we want to get these on quickly and up titrate these Entresto, once they're on both and they're tolerating. I don't know, Poppy, if you have anything that you would say different to that.
I think, that's one of the really tricky things around talking about guidance as well, isn't it? Because the guidance would tell us that we do everything else first, and then this is an add-on once we've done, already standard therapies. but it depends. We want to do it as quickly as possible. So, you know, you guys are saying you give them the Entresto and then the DAPA to start a week later. We've done a bit of that. I would do that in a very robust patient who I was confident was going to tolerate that. But there may be some patients who are actually already on an ACE inhibitor or an ARB instead of Entresto, and we haven't got to the switch yet, and I'm really worried that their blood pressure isn't going to tolerate the switch, then I might give them an SGLT2 instead of switching them to Entresto. I think it's really sort of depends on the patient in front of you and what their blood pressure is, what you think they're likely to tolerate, how much they're likely to understand, because, you know, the change of Entresto is quite complicated. If they're already on an ACE inhibitor, they have to wash out for 48 hours before we can switch. So it does vary, doesn't it? But definitely as soon as we can, basically.
I also quite like giving my patients the choice, because frankly, in heart failure, unlike diabetes, but I think this came from my diabetes thing where I spent 12 years trying to get people to take more medicines. I just quite like saying to patients, this is what I want you to do. These are the things I've got. These are the toys I've got. Which one do you want? Because when they pick it themselves, my God, they'll actually take it. You know, like
compliance is so important, isn't it?
And some of them are quite scared of the Entresto and the blood pressure and stuff like that. And DAPA seems like or SGLT2 seem like quite an easy one to do. So I often find my patients choosing that first, and I'm happy with that. You know, like I don't. So often I sort of say to them, this is what I want you to try, and things like putting in Imperanone or Spiro can often be harder with hyperkalemia. So I often will reserve that for after I've got the Entresto and the SGLT2 in place, because then I can faff around with hyperkalemia later. So I think, you know, that patient, and that really reflects what we see in diabetes, right? When we've got choices and we're trying to say to people in diabetes, what do you want to do? Which one do you want to take? And I think that crossover is very similar.
Yeah. That kind of answers one of the other questions then. Can you use Entresto with an SGLT2 inhibitor?
Absolutely.
Yeah.
Are there any more questions? We've done the sick day rules.
Guess that's a good time to bring in maybe what medications maybe you guys in heart failure are nervous of about if you see someone with diabetes, what medications you're a bit nervous of, or what ones you would titrate out or in, or do you just contact DSN or your special pharmacist that you have, which we all save our lives many a time. I don't know who wants to answer that one.
I think I'll probably speak for everyone when they say insulin. I think insulin puts the fear of God into everybody. Hang on, I'm really sorry, one of my children's just come in. Maybe one of the other nurses can start with what they're nervous on.
I agree, insulin. I mean, I personally wouldn't change any of their diabetes medicines. I don't see that within my prescribing competency. So if I'm worried that something is going to need to change, then I'll be contacting the diabetes team that's looking after that patient. So, you know, if they're just on metformin, then the diabetes team advise us not to worry too much about that. But obviously we are checking people's HbA1c. But anything more, then I kind of feel like I need to chat to them about it, but I'm definitely not going to change it myself. How about you, Becky?
Yeah, I'm the same. I would definitely say to the patient, who's your diabetic team? Who can I talk to? Let's find out what's the right thing to do. I would be really reluctant to do. And, you know, even that means we're pausing, thinking about DAPA until I know for definite what's safe to do. I think that's the right thing to do, probably. I think as much as you guys seem a bit nervous about heart failure, I'm equally as nervous about diabetes. So, you know, it's just about talking to people who know more about it than me and making sure the patient's safe.
I think that's the same. And throw in the kidney stuff as well. And we're all just
definitely.
I think, you know, I think someone's mentioned it about, you know, these multi-morbidity clinics. So I know, you know, so I'm in a really weird, unique position, having worked in both specialties. So have much more confidence in just going, I'm just going to get rid of this gliptin. I'm going to stick in some DAPA. You know, oh, you're on glycoside, right? I'm going to tell you to halve that while I put my DAPA. Like, that's comfortable for me, and I know that there are other clinics. So I know Claire Davies up north, who is also a pharmacist, runs a multi-morbidity heart failure diabetes clinic with another pharmacist colleague. Actually, there's no one else involved in this, where they see the patient at the same time. And I think from a patient's perspective, that's so much better, right? That they're getting whole holistic, all do round at the same time kind of thing. I mean, my clinics are really interesting in that the endo consultant is running a diabetes clinic and the DSN is running a diabetes clinic on the other side of the corridor. I can actually knock on a door and go, broken, what do you want me to do about this? But I do think like bringing those teams together to think about how we do patients, or if we know that we've got someone coming up in our outpatient, maybe asking an MDT before the outpatient thing so that you're empowered to do it. You know, obviously that requires alignment and whether you're having weekly MDTs and things like that. But I think there's a lot to be said for this multi-morbidity working and trying to have clinics at the same time, or being empowered as a non-specialist to make small changes, or asking primary care. If primary care are in diabetes, they're not a type 1, they're not on these complex things, saying to them, you know, like I sort of say, especially with the insulin, I tell the patients to keep an eye out for hypos and to reduce their insulin by 10% if they start to see them, and to contact the team that is normally looking after them to really titrate it. And then I say in my outpatient letters, you know, I really want this patient to be on this dapagliflozin, so please titrate their insulin up or down to achieve, you know, a blood glucose target of 6 to 12. You know, now part of that comes from my diabetes knowledge, but I'm empowering the other team to do their bit they're already doing. And I think that kind of cross-sector working is really important.
Definitely.
Yeah,
primary care practice nurses and GPs, they've been doing multi-morbidity clinics since day dot. I think we need to be a bit more like that, I think, in specialist care.
Yeah. We've got like renal diabetes clinics, haven't we? We just don't seem to have picked up the cardiology side of it very well, but I think that is because, I don't know, ECGs and all of that scare me to death. So I think we definitely need to work more closely.
They can scare me too.
Think, you know, a big part of this
It's just a bunch of wiggly lines.
Oh, good.
The thing is as well, isn't it? It's like now we've got a drug that crosses both both specialities. I think that's the thing, isn't it? Is that, you know, whereas I think before, obviously with renal, because there was, you know, renal dialysis and there was a lot of diabetes patients going for that and things like that, they started those clinics to try and cut that back. Whereas, you know, heart failure is like the new big thing that's linked to diabetes now. So you know, they're going to be sort of starting clinics up, aren't they, which are going to be cardiology kind of diabetes clinics, and, you know, seeing who goes where. It's whether the heart failure nurses end up in the diabetes clinics or the diabetes nurses end up in the cardiology clinics. You know, it's going to be one or the other, isn't it, I think.
But interestingly, renal and cardio work really closely together, because so many, I genuinely had no concept until I turned up on the cardio ward how many patients have dialysis on a cardio ward, and you're there going, wait a minute, I didn't think I was going to be doing renal, but actually it's half of the job of the patients that we see. So I find it really funny that renal will play with both teams, but no one else will talk to each other. It's really funny, like the politics and the kind of sociology and psychology. The diabetes and cardio don't speak, but everybody else will speak via renal. It's random.
It's funny. And I remember when the SGLT2, like all the HFrEF and all the HFpEF started coming out, and it was still very much then like, oh, it's a diabetes drug. And do you remember all the webinars at the time were, whose drug does it belong to? And it's still, there was that divide between, you know, if they're going to start an SGLT2 in cardiology, get the diabetes team involved. And so, yeah, we see a lot of those referrals now still from cardiology to our team, but saying, starting an SGLT2, do something about it with the diabetes side.
Yeah, the diabetes team don't have capacity. I mean, they were very much.
Well, I mean, like,
we cannot deal with this. You know, and the diabetes team, you know, are like, we avoid heart failure on the ward. They're like, oh, it's heart failure, we don't understand that. And I'm like, you can't not understand it. Like, it's half your patients. You know, most of the patients I meet are just the diabetes people I used to see in clinic on a different day. Like, they're not, the patient is the same person. They've just got more than one inconvenient chronic condition, and it's kind of, you know, like, it's been really bizarre crossing boundaries and seeing it from both sides. And like, I always thought that I kind of knew enough about cardiology till I worked in it and was like, oh, it turns out I didn't. But the crossover is, it's not actually that hard, because it is actually the same drug. And I think that's the thing, that we draw those dividing lines ourselves. You know, like, you know, Poppy and Becky were sort of saying, you know, I don't do diabetes because, but actually I guarantee, you know, like a third of your patients at least have diabetes, and you kind of sit there going, you know, and it's not you personally, it's like all of my heart failure nurses all sit there going, and they'll all knock on my door during clinic hours, and they'll be like, is this okay? And they've done the right thing. They've 100% done the right diabetes thing. They just need someone to say, yes, it's okay. So it's kind of like, I guess, encouraging people to kind of maybe do double specialties, so that there's one person in each team that can nod and go, yeah, it's okay, because that's really all that's needed.
Yeah, I think somebody in the chat was saying that they're scared. You know, heart failure nurses are scared of diabetes nurses are scared of heart failure, and we just don't feel comfortable. Things like changing medications and stuff is quite
but
scary.
what
But
would
it's education, it's education,
yeah,
isn't it? We all
say, but what would make you feel more comfortable? Like, I wonder if you went and sat in on a couple of clinics.
I think these multi-morbidity clinics where we're doing them together, and we're sitting in together, and so we're kind of seeing that's because like you said, it's the same patient.
And I think also forums like this as well, like I think us getting to know each other, I think then it's asking a question from somebody that you know, it's easier than, those barriers are broken down if we have collaboration like this, and start to realize that neither specialty is really that scary. We just need to learn a bit more about it, and then be more collaborative about it.
And the drugs are the same. They're still ACE inhibitors. They're still beta blockers. Like, the diabetes teams are still putting those on all their patients for hypertension, for AF that they're doing. They're putting them on statins. Like, SGLT2s are the same. Like, the drugs haven't changed. So the drugs are the same. They have the same risks, the same side effects. It doesn't matter which patient you're putting them in. So when you look at them like that, actually you know far more than you think you know, because you're still doing the same things. If you put an ACE inhibitor in a patient with diabetes for hypertension, you're monitoring their blood pressure and kidney function. It's exactly the same in heart failure. So it's an interesting concept that it's a scary thing to do, because you've done the same thing day in, day out. And when you get people to look at it like that, they kind of go,
oh yeah.
But there's an interesting
questions. Beth,
I was going to say, the one about there's one saying that DSNs perhaps have gone out, and I'm not saying the heart failure team haven't done this, but it's something that DSN's been doing for a while, is going out and doing clinics with practice nurses, and kind of maybe working together there. Is that something that you guys do? Do you go out and do education with practice nurse or GP teams, or are you very much kind of like the outpatient style kind of thing?
So most of our clinics in North Devon are based in community hospitals or the main hospital. So we are out, miles away from the main base, but it's usually at the community hospital. In the last year, my colleague and I have been trying to go out to all of our GP surgeries to give them a heart failure update, because so much has changed, and we're gradually working our way around. But it's very variable each practice, whether the practice nurses are attend that training or whether it's mainly the GPs. So I think we do need to find another way that's sort of nurse focused. And I think this year for Heart Failure Awareness Week as well, we're very much looking at how do we actually get out to nurses in general, not just practice nurses, but nurses on a wider scale about heart failure, not just preaching to the converted and all our colleagues who already know about heart failure. So yeah, it's definitely an important part of it. And locally, I see what you're saying, Beth. I do see our diabetes team are on it with the practice teams. They know them all. They have regular meetings, and we could learn a lot from that. But the resource is a big issue and barrier to us doing that, definitely.
Can I just add to that? So in Bristol, because I'm just up the road from you, Poppy. So in Bristol, when I turned up, there's primary care, there's Sirona who do our intermediate care kind of stuff, and then there's us in secondary care, and it was a bit of a shambles. Everything's all over, but we had de-skilled primary care entirely out of heart failure. Like, it was, as soon as they had a BMP over 400, they referred to Sirona, and then if they got ordered directly to us, and if they were inpatients, we kept them, or Sirona kept them. Like, we didn't do anything. And I came from diabetes and working with these guys and doing all that, and they just created the DIAST model. I say they did, like Hannah Bieber, who is one of the big pharmacists in Leeds, and they have this beautiful triangle where they have specialists, medium people who are just doing kind of the basics. And I literally stole the beautiful DIAST model, took it over to heart failure and went, turns out it's exactly the same because it's a chronic condition and everybody's interfering, and set up an education program. So we currently in Bristol have 30, both nurses and pharmacists. We've got both of them together at the same time, and we're doing competence training. So we're doing a whole program of education, mentoring, getting them to do personal development plans, stuff like that. It's running for 6 months. It will run till July, with the idea that by September, these are guys that we can refer directly to with a proper care plan who can just take over, where we can lessen the thing on intermediate care. So there's massive things, but I literally stole the diabetes model because it's the same. So, you know, like what you're saying, so, you know, like the education is good, but what we wanted was the competence, because obviously they can all turn up and listen to some words and then go back to what they were doing. And what we were really worried about was nobody signing up because of capacity. You know, we don't have time. We had a waiting list of 10. So we had 40 people try and sign up to our 30 spaces. So I think the appetite is out there. And, you know, it was all funded by the CCG. They funded it all. It nearly fell over because I've been trying to do this in diabetes for the last God knows how many years, and like heart failure, everyone was suddenly wanting to do it. But there's massive thing, and I think these models kind of that are in other chronic conditions are really great, because it all works the same, doesn't it? You know, like, you know, it's the same thing. And like these guys are like all on it. I mean, the secret weapon that I have is that I'm going to have them defined as a specialist, because it means I can bounce DAPA and Entresto initiation and titration out of them. You know, like to lessen the impact on everything. It's the same sort of thing, you know, like these guys, diabetes teams are getting insulin started. Insulin used to only be started in secondary care, right, and by specialists, and now you've got primary care nurses doing it. It's just that heart failure is about 5 years behind where diabetes is now pushing forwards.
Yeah, and you know, we talk about workload and we talk about capacity, and what you described there, that sounds amazing, and it requires a lot of work, but actually that's then going to pay off down the road for the workload and capacity, isn't it? So you know,
and that's what I sold to the CCG. I couldn't believe the CCG funded it. I nearly fell off my chair when they gave me all the money, I'm not gonna lie. Like, I kind of thought I'd put in a cheeky bid and see what I got away with. Because they knew that there was a massive problem with the whole system, I basically process mapped their system for them to show them how broken it was, and they were like, oh, this is not going to be fixed easily, and then presented them with the solution, which they then gave me money for. There was lots of benefits to it. And like,
I mean, that kind of thing sounds like what like diabetes nurses could maybe go to, because the idea, like we said the other day on something we did, the idea of doing a whole nother master's degree and a whole nother speciality is like kill me now. So it's kind of doing like little modules or little things like that, isn't it?
Yeah, I mean, I think with stuff like this, I mean, we're doing 4 workshops, 2 online and 2 face-to-face, so everyone meets each other, and we're doing one-to-one mentoring via Zoom, and we'll go and visit them once. Like, it's not complicated, and it is about capacity, but exactly what you're saying, there was no set list. You didn't have to be doing certain things, you didn't have to be, but those kind of things locally. And I think bringing in other specialties actually makes it even nicer for DCGs if you're asking for funding, because they're talking, it's not exclusive, you know. And I think things like that, it seems to be quite a good way to go for the future. And diabetes started it. It was the DIAS program that started it.
Okay, so we
did do a brunch about that, didn't we?
We did. We've done a lot about primary care. So I'm conscious, Tamsin, you work in inpatients, don't you? So did you want to ask any questions about inpatients, diabetes, heart failure, crossover?
I mean, I think, you know, we were talking about it, weren't we? I think earlier about starting it in, you know, very sort of acute patients who have come in and starting different medications, and there is certainly some trial data that's coming out to say that actually the earlier you start medications the better, but I you know, I certainly know in my area, you know, I think I'm a non-medical prescriber as well, and I would probably be quite happy to prescribe these medications, but the thing is that we see these patients all the time, whereas actually my consultant team, who don't see these acute patients because they don't go out and review these patients like we do on the wards, actually are a bit more kind of cautious. So we're in a bit of a catch-22 situation between our own team in a sense. But what would your thoughts be on actually starting you know, these diabetes SGLT2 medications in the acute setting?
So we do prescribe DAPA in hospital. It tends to be when they are at the tail end of an admission. I I would say. So we've got them over their acute heart failure, and we're just optimizing things in part of their discharge planning. But we are prescribing it because just the quicker, like you say, the quicker we get them on, it's one less thing to do as an outpatient referral, and it just benefits the patient. I guess if we had any questions, there's a really good inpatient diabetes team at Salisbury, so we would always ask them if we had any questions about particular meds.
Do you have any concerns about starting it in inpatients? I know people worry about DKA.
I think DKA is a really fascinating one, because when SGLT2s first came out, my DSNs were dead against them because they kept seeing the DKAs coming in. They were the ones who saw as inpatient admissions, DKAs, euglycemic DKAs, like these drugs are horrific. And I had to keep highlighting to them that they had this kind of bias because they only saw those ones. They were seeing, whereas the thousands of people out in community that were merrily bobbling along. But I think we've
just explain that term you just used, euglycemic DKA, because some people won't have heard that before.
Okay, DKA with no rise in blood sugar. So the DKA is associated with SGLT2s. You get normal blood sugars, but you get high ketones and acidosis as a result of it. So it's diabetic ketoacidosis, which is the exact same, but you don't have the high rise in blood sugar, which is what we normally associate with DKAs with our type 1s.
Yeah, because of the mechanism of action of SGLT2s, all the sugars being peed out, so you don't see that high sugar level.
But the thing is that all of this tended to happen at the beginning when we didn't know about SGLT2s and we were prescribing them in our frail, elderly, high blood glucose patients. I say we, the diabetes people, I'm not we them anymore, have learned a lot. We don't tend to start them in those kind of patients anymore. We don't tend to start them in the aggressively risky patients. We tend to be back off from that. Now, so there seems to be less of it coming in, and we've learned a lot. And if you look at all the trials, even in heart failure and kidney disease, they exclude those patients to a certain extent. So a lot of the trials don't. Okay, we'll keep going. Sorry, children. They tend to exclude the high HbA1c. So I think HbA1c greater than about 80 or 90 in the trials are excluded. So, bearing that in mind, which is why in my cardios, I tell them that if they've got HbA1c over 80, they need to ask advice. It's not that they can't do it, but they need to look a bit more closely at diabetes first. Does that make sense? So when we're talking about the acute setting now, I think all this conflicting advice during COVID, everybody was told to not prescribe SGLT2s because COVID also caused DKA, and these people who were on SGLT2s got more DKA in COVID times. COVID's now very different, and what we don't want to do is stop them when they come in and keep them off it for their entire inpatient, which is what we were told during COVID. Now we're saying we'll stop in the first 2 days, see how they're doing. Once they're a bit better, we can restart it again. But those messages aren't getting through. So we've got all this conflicting stuff about DKA. And the risk of DKA is still very low. Statistically, in the trials, it's incredibly low, but we're treating all patients like they're all going to get DKA. And I think, we had a little quick discussion before we started about risk aversion, and it's really funny. So the cardio team think that diabetes are way too risk averse. I think they think that everything's going to be a disaster. The diabetes team think the cardios are way too off-piste, maverick, it's going to start it on everyone. And that conflict, a political conflict, is a lot where patients fall in the middle, because you've got the cardio teams going, yeah, just start it on everyone, they'll all be fine, and the diabetes team saying caution. And really, the only way to get across it is to find a place to compromise. So for my team, I said they have to do HbA1c on everyone. So I make sure that every single person started on SGLT2 has a HbA1c done in hospital, because it's really easy for us to do it. And if their HbA1c is below 50 or above 80, they're not allowed to prescribe it till they've spoken to either me or the diabetes team. And there aren't actually that many patients that meet that criteria. Most are sat there quite happily in about 60 or 70, bobbling along. But what it's meant is that the cardios feel much more confident. The nurses in the DSNs feel much more confident that we're not going to make people go hypo or DKA. And we can work in those structures. The few people that fall outside it require a little look and a quick fix, and then it's all much better.
We found lots of people who have not had that diagnosis of diabetes when you've been checking HbA1c in heart failure patients.
Yeah, there's absolutely tons. I mean, saying that we found one the other day who had a HbA1c of 100, and he just, new diagnosis. I've got two next door to each other on the ward, both with new type 2 diagnosis.
That missing millions, isn't it?
It is the missing millions, and it boggles my brain that cardio don't think that HbA1c is a thing that you must do on every patient that walks through, because we know that diabetic and cardiology go hand in hand, diabetes. So it's something that I make sure that I do, and I certainly do it on the SGLT2s, to make sure that I'm not going to put them at risk of that DKA. We can't predict exactly, but we can eyeball the patients and go, this. We will start DAPA on people who are 90. Like, we will do it because they've got heart failure.
That gives us palpitations.
Yeah, exactly. And this is the thing that's really funny, isn't it? Like, I can see your faces and you're like, big God above. If they don't have diabetes, their risk of DKA is virtually zero. So if I'm giving it to them for their heart failure and it's going to stop them being admitted to hospital with decompensated heart failure, why wouldn't I do it?
Yeah. Do you think the new NICE guidelines, we're going to see more people inappropriately prescribed?
Potentially, because I think, sorry. Go and do it yourself, you're perfectly capable. Sorry.
Love it. So the new NICE guidelines, do you
yes.
think?
I think we potentially will. I don't know. Primary care have been trained in diabetes, so their brain is in diabetes. Okay, so that's the bit that they're going to be thinking of before they think about heart failure, before they think about kidney disease. So I don't think we're going to see a massive drastic thing. What I think we will see is a lot more requests for advice and guidance, for example, saying, I think I should do this, but I'm not sure. I suspect that that's going to be, and that's where the communication and the networking really needs to come in, because, we in heart failure, NICE have said, no one is to start DAPA apart from the specialists. So, and the same with kidney disease, or not the kidney disease, but the heart failure ones, it's sort of be started by a specialist or recommended by a specialist. So it puts that barrier of complications away. Like, primary care won't be starting it for heart failure. So ultimately they are still starting it for type 2, and that's what they've been doing all along.
Yeah. Well, Poppy, if you've
Yeah,
got a question.
Oh.
Yeah, sorry, just for if there are any heart failure nurses watching, in regards to DKA, I mean, a lot of community heart failure teams sort of run their service with a very open phone line to patients, and often if patients can't get hold of their GP, they ring us about anything and everything that's wrong with them. They're generally unwell. I mean, we've had patients on the phone while they're having a stroke, having chest pain. So and when they've got chest pain, that's our comfort zone. But if we've got a diabetic patient on an SGLT2 inhibitor and they phone us up generally unwell, a bit confused, stomachache, nausea, when should we be thinking, okay, this patient's at home 30 miles away from me, could this be DKA? What are the red flags? What should we do? Should we have urinalysis kits in our stuff that we take to clinics for patients? What should we be doing to be vigilant and be looking out for those DKAs as heart failure nurses?
So for testing ketones, we always use blood. Urinalysis is a bit delayed. It could have been sitting in the bladder for 4 hours, and you're not getting the true picture. So I think blood ketone testing is a surefire way to find out if someone's got ketones that are causing acidosis. Usually they're about above 3, I would say. Ketones of above 3, but anything that's kind of heading that way is in the danger zone.
So if we haven't got access to that, which patients
you can get any rep company that has meters will give you a ketone meter free of charge.
I'm pretty sure every DSN team would as well. Like, I know my DSNs would happily hand over some ketone meters for the visiting nurses. It isn't hard to do any of it.
Okay.
Yeah, you might just need to buy some strips, that's all.
Okay.
Or get your pharmacist to give you some.
Yeah, that's very useful. Thank you. What about the patients on the phone? Which ones should I be sending in to have bloods, or for somebody to look at them?
I mean, if they're unwell like that, they're saying they've got the DKA, your signs and symptoms, they start getting breathless, but then your heart failure patients will already be breathless, don't they? They can get abdo pain, feeling sick, clammy. If they're not on an SGLT2 inhibitor, we would usually see high blood glucose levels, but with the SGLT2, it masks that, so it's difficult to know. But yeah, I mean, the only real surefire way you're going to know if it's DKA on it is having bloods done, and if they are that poorly, then hospital.
Yeah, I mean, I think even as DSN, we have quite a low threshold as a community DSN, because we have patients ringing us up on the phone, and we would go through sick day advices and stop the medications that might be putting you at risk, which are the ones we kind of talked about. And there's a little algorithm that we have posted in the chat, but it's sad man, so I'm sure people can go and have a look at that. But you know, we would say potentially, depending on what those ketone levels are, and most of the patients that ring us will say, what are your blood ketones? They go, I haven't got a meter, or I haven't got any strips, or, you know, that kind of thing. So you're kind of scrubbing in the dark. Yeah. So quite often it would be, you know, just ringing them up every couple of hours and monitoring them, getting them to make sure that they're testing their blood sugars more frequently, drinking at least like 100, 150 mils an hour, trying to flush the ketones out. But we'd have quite a low threshold if we have no way to test, to just sending them in, really. I don't know about you guys, but
yeah,
we
you
try
need to know what the pH is, don't you? And you're not going to be able to get that over a phone call.
Yeah. I guess the other thing as well is, from a heart failure perspective, is if they're feeling really that unwell and stuff like that, we also want to make sure they're not decompensating from a heart failure perspective, don't we? So, like, you know, like you'd say, Poppy, like if they're suddenly becoming breathless and they're feeling ill, it's worth just getting them to come down to get checked out quickly, because we can tick all the boxes and maybe tweak their diuretics if they need it instantly to stop an admission. So
yeah,
I mean, and you know, that's obviously what you end up doing for heart failure reasons or chest pain reasons or whatever, but you know, we get lots and lots of phone calls. I would say we probably, you know, I probably take about 40 phone calls a week, and all of my team do, and you know, every couple of weeks you'll admit somebody. You go through the red flags, don't you? You're not going to send everybody in that phones up feeling unwell, so it's which ones am I going to send to the GP, which ones am I going to send in, which ones that can I kind of do something over the phone, like you say, tell them to drink more, actually should we be holding some drugs. It's kind of getting a sense of it. And I think you know, a lot of what we do is spidey senses, isn't it? We take all the science and the information, and then you get your spidey sense. And I've got my spidey senses well honed for heart failure and for chest pain and for palpitations, but not for, you know, could this be DKA? And actually, even before we were prescribing these drugs, you know, we have patients who were diabetic who potentially could have phoned up generally unwell with a DKA, but it wasn't as much on my radar. And now I'm like, oh, okay, should I be thinking about that? But I think
we also have to remember that this is actually really quite rare. And so it's unlikely that you'll see anyone, you know, you might see the one now and then. I've only ever seen euglycemic DKA about 2 or 3 times, and it's those patients that have a low beta cell function, they're not producing enough insulin, maybe those that are on insulin and they've reduced it when they've started an SGLT2, or those people that are really sick, so they've gone nil by mouth, maybe for surgery, and they haven't stopped the SGLT2 inhibitor, or they're just really, really like that COVID, you know, they've not eaten and drinking, they've been in bed all day, they're dehydrated anyway, but they still take all their tablets. It's those kind of people that I would be. So the history taking, I think, is really important. You know, what's been going on the last few days? Have you been eating and drinking? Has anything happened to mean that you maybe are at risk of this? And what's their normal medications like? Are they on insulin? Do we know they've got a low beta cell function? Because they're your risky candidates.
And I think it's historical as well, isn't it? I mean, for us, as an inpatient nurse, I actually do see euglycemic DKA quite a lot. But when I go and speak to the person, I usually find that they've been on SGLT2 for years and they've never, ever been told to stop taking it. So we're much more proactive now. We're much quicker at telling people, don't take this medication. If you're not eating and drinking, if you're starving for surgery, if you're sick, any of those things, we say stop taking that medication. So I don't think I've seen anybody recently that has been started on it within the last, year or so. The people that I do see are people that have been on it for a length of time and they just never got that education. It was maybe started, a bit randomly. It could have been, it may have been discussed at some point in an appointment and then they started it. And, there's been no follow-up from that point of view. And obviously during COVID, people got seen less and less. So, they just never had that follow-up information that they should have had, really. So whilst we do see it in hospital and in my area, it isn't for the new people that are starting for, whatever reasons.
And I think that's something to really, one thing is that a patient's heart failure is not going to decompensate if they stop taking it for a couple of days. So if they are presenting with those symptoms, or, you know, telling them that it's okay to stop it for a few days is fine when they're ill, that's not going to hurt them. And then the second thing is about, as you say, about the education, like there are lots of nice leaflets produced by one of the companies for this drug in heart failure and this drug in CKD. So I always give one of those leaflets out when I start it. So if I'm sending a prescription out, I send the leaflet with it if I'm doing that, so that they've got it written down. And, you know, like community pharmacies and, you know, annual reviews, those kind of emphasizing, you know, there's lots of things we want to counsel our patients on, but those kind of risk ones are really good ones to remember to try and do all the time, isn't it?
Yeah, and I think we're near enough out of time, guys. We've been talking for a whole hour. Can you believe that? It's just amazing that we've got so much in common. We've got so many things that we're, you know, that we're equally concerned about, and we equally, you know, we need to work together more. I think having more of these kinds of conferences and webinars and things where we all do things together, so that we can all kind of share the love. So watch this space. We might be planning something in the future. A joint collaborative something or other that's a little bit of a secret at the moment, but yes, watch this space. Thank you all for listening, and thank you to our excellent speakers and Vicky's children for making
I know what I was going to say.
Oh yeah.
Can Poppy and Becky say what your nurse forum is, so that all the diabetes nurses watching can go and follow you all on Twitter and everything, so that we can have more of this learning from each other? I don't know, because I know like ours, we kind of obviously we're DSN, so we kind of advertise all of our other stuff across social media, but I don't know if you guys are sort of a closed group or if you welcome anybody in. But just so let us know what your hashtags and things are, and I can type it in the Facebook chat as well, and then we can all go and follow each other.
Yeah, so we're on Twitter, we're at BSH Nurse Forum, and there's also British Society of Heart Failure on Twitter, and obviously there's a website for British Society of Heart Failure. There's a lot of webinars that BSH and podcasts that they've done that are free and downloadable on the website. People can join BSH, that does cost, it's free for students. So yeah.
Cool, so we can all go away and look at that.
Brilliant.
Some weekend homework.
Yeah.
Thank you.
Right. Thank you so much, everybody, and we'll see you next time. Bye.
Bye. Thank you.